I would like to welcome Professor Dr. Yasser Wally, Professor of Pediatric Hematology and Head of Department of Pediatric Hematology, Sultan Qaboos University Hospital.
Assalamu alaikum wa rahmatullah. First, I would like to thank Professor Amal Bishlawi for inviting me for the Thalassemia Day celebration in Egypt. And I'm very happy to see all the usual faces when I come to Egypt. They are my professors, teachers, and colleagues. And also I saw Ahmad Tarawa from Saudi, Salam al-Kendi, without Alqab, from Oman. He is a retired professor like me, because he's in the same corridor of me, so we're meeting even always every day. And we were the HODs, head of departments together, and then we are downgraded together. So my topic is very simple, iron deficiency anemia and management updates, and there is not much updates, but I'm going to focus on some clinical tips and some difficulties in the diagnosing iron deficiency anemia, particularly for the clinicians, not for the lab persons. So I'm not familiar with using this, but I don't know how it works. كده من فين؟ So these are some beautiful, some beautiful sceneries from Oman, and I invite everyone to participate in the Pan-Arab Hematology Conference next year, February 2000. What do you say? In Muscat. So, these are some very nice, beautiful views from Muscat and from the Sultanate of Oman. That one in particular, it's the very famous Turtle Beach, which is in the eastern region of Oman, where turtles travel 13,000 miles from Australia to Oman to lay these eggs, very precious eggs. And that's what is going to be discussed. These are for my adult colleagues, because they don't know that at all. So my adult colleagues, they don't know that the hemoglobin differs from the newborn till the age of 2 years, and then gradually, at birth, it is the MCV is very high. Almost the mean is 108, and the hemoglobin is also high. But at the age of 2 years, usually they come to 12, and the MCV come to the range of 70s, which is the range in adults. How to define iron deficiency anemia, as we all know, is the most common nutritional deficiency in infancy, and mainly it is the disease affecting children below 5 years of age. It is common, still common even in the developed countries. So how to define it? It is a state in which there is insufficient body iron to maintain the physiologic functions. Very simple definition, which persists. And for the laboratory people, they prefer serum ferritin below 12 in below 5 years of age, and below 15 in those older. And the anemia, since I was a medical student, it didn't change. It is low hemoglobin values. We have to consider the gender and age. The WHO organization uses the following hemoglobin thresholds to define anemia, which are very important. So in children below 5 years, if you have a hemoglobin below 11 grams, this is anemia. However, we should take that very cautiously in areas where there is prevalence of alphathalassemia trait. Otherwise, we'll label most of the children are anemic, but they are not. Like, for example, in Oman, United Arab Emirates, and I think in some parts of Egypt also, there are the hemoglobin normal we can find in a child of 3 years old, a 10 or 9.5, even with a low MCV, MCH, because of the alpha-thal carrier, and I'm going to talk about this differential diagnosis in my presentation. So you have to be very careful of diagnosing anemia, particularly in, it is usually by, not by you, of course, but by medical, general practitioners. They prescribe a lot of iron, and you can find a child who's 6, 7 years old with black teeth because of unnecessary use of iron in this population. And I have seen also some cases here in Egypt. The prevalence, you can see that of iron deficiency anemia, that in most of our countries are having, so are in the region of severe, moderate to severe prevalence of iron deficiency anemia. In Canada, for example, they have almost less prevalence, and in many developed countries. But our region still, we have high prevalence of iron deficiency anemia. Very few words about the pathophysiology, that we have a lot of mechanism controlling iron absorption, but for iron secretion is almost negligible. Usually, how to get rid of iron? Only to get through the shedding of the mucosa. So we cannot lose iron. Mainly the physiology of iron is dependent on the way we absorb iron. Also, 3% of the iron is bound to critical enzyme systems like catalase, cytochromes, neurotransmitters, and this is very important for the non-hematological manifestations of iron deficiency anemia, mainly the neurological manifestation, because this small percent of iron is very important for the function of these very important enzymes. And 30% of the daily iron come from diet. So what about the other 70%? Is recycled. So like exactly what we do, recycled from the reticuloendothelial system. So the iron hemostasis, as I told you, is regulated through the intestinal absorption and the transport. The absorption is regulated by the very famous hormone hepcidin, which acts primarily on ferroportin. Ferroportin بالضبط زي البواب. It allows iron, which is a transmembrane protein, that allows iron either to go from the intestinal mucosa to the blood, and vice versa from reticuloendothelial cell to the bloodstream, increasing iron in the system when it is needed, and vice versa. It blocks also the iron movement. So the serum hepcidin, whenever it is low, then the intestinal absorption of iron is very high. That's why in thalassemia intermedia, for example, because of the very low hepcidin, the intestinal absorption of iron is very high. And low iron stores result in hepcidin suppression, as I told you, increasing the gastrointestinal absorption of iron. Okay. This cartoon demonstrates that, so you can see the ferroportin. This is the intestinal mucosal cells, and when the hepcidin is low, this will allow the iron to go through the ferroportin to give more iron for the transferrin, which is the iron protein carrier of iron. And then iron overload, it is exactly the opposite, so there is a blockage of the movement of iron through the ferroportin. Now I'm come to a very important clinical tips in the pitfalls of diagnosis of iron deficiency anemia. So our region is different. I'm talking not only about Oman, but about also many areas in the Gulf, and I think in the Middle East, we have high prevalence of iron deficiency anemia. And Professor Salam Al-Kindi among the audience is the one who started the, what you call that, newborn screening program for alphathalassemia in Oman. And we also for sickle cell, all the blood disorders. And currently it is done in the university hospital, but there is a plan to increase it. So what we found so far is we have 55%, which is a very high percent of alpha-thalassemia carrier in Oman. Though, as this slide states, that it will come later. Anyhow, so we all know about alpha-thalassemia. It is, we have 4 genes controlling the alpha chain, and the clinical phenotype is based on the degree of the impairment, how many alpha chains are involved. So normal is like that 1 gene deletion. This is called silent carrier. 2 gene deletion will cause some microcytosis, hypochromia. In our area, this is the prevalent type. In eastern part of Asia, Southeast Asia, this is a common type. That's why they have more of hemoglobin H disease, because they carry the 2 alpha on one side of the chromosome. 3 gene deletion will result in the hemoglobin H, and 4 gene is reflecting the hydrops. So this is actually from the Sultan Qaboos University website, hospital mid-track system, and you can see that alpha thalassemia is a clinically insignificant. So in the newborn screening, this slide shows that this child, this newborn has got Bart's hemoglobin in screening, and that's why he is labeled as alpha thalassemia trait. Not only that, if you look, you find that the hemoglobin F is very high, 83%. So most probably is also a carrier of beta thal trait. So that's why in this child with the 2 carriage, his hemoglobin will never cross 9.5, and he doesn't need any iron. Usually they have good amount of iron because of some ineffective erythropoiesis. So there will be increased gastrointestinal absorption of iron. So they don't need iron usually, and they don't develop iron deficiency anemia. But these children are up till now given iron and get a lot of side effects unnecessary. So مش عارف شايفين ولا لا، بس الهيموجلوبين هنا is 9 صعبة. Anyhow, severe microcytosis hypochromia. I'm sorry. طيب. Anyhow. ما بتحرك. بس ما فيش مشكلة، هو it is not important. Anyhow. شكرا دكتور منى، جزاك الله خير. الهيموجلوبين is 9.9. What I want to say in this slide, in this slide is that the MCV, MCH in alpha thalassemia trait are very low, 56, and the MCH is 19, يعني very low. And you can look into the red blood cell mass, how much? Above 5 million. So child with a hemoglobin of 9.9, his red cell mass is very high. And this is the most important indicator of alpha thalassemia. The red cell count موجودة فوق. red cell count count. The red cell count 5 مليون وشوية. أنا آسف. Red cell count is 5.something million, which is normal or even close to the upper limit of normal. But the MCV, MCH are very low, and the hemoglobin is borderline. This means an alpha thalassemia trait. So this child mostly doesn't need iron. لكن it is even more important than the RDW. You can see here RDW is borderline. It is 16 only. It is usually normal in alpha thalassemia. And the same child has got a hemoglobin F of 76% at birth, and also there is a hemoglobin parts which is very, what we call that, the hemoglobin parts is very low. Is detected, sorry, at birth. So that's regarding alpha thalassemia. Anyone wants to ask anything about this prevalence of alpha thalassemia and how we detect it? Okay. So the detection, usually if we want to confirm this, we need to do a molecular testing, and we have the molecular test in the lab. We have both alpha thalassemia. We do the deletional and the non-deletional, and we have all of them common in Oman. And we had a grant. We collected money for doing these tests, so they are now almost done routinely. If you want to diagnose alpha thalassemia at molecular level, because those are coming at 1 year of age, you cannot detect the hemoglobin parts anymore. So we depend on a low hemoglobin or borderline hemoglobin, low MCV, low MCH, and a high red blood cell count. Usually high blood, this discrepancy between the hemoglobin and in iron deficiency anemia with the hemoglobin of 9, we'll find the red blood cell count of 3 million, 3.5 million. So it match. But in alpha thalassemia, this matching is not there. How to prevent? I'm not going to go through that because this is very simple. And the clinical manifestation, since we were medical students, is the same: microcytic hypochromic, hypoproductive state with low retics. In alpha thalassemia, there is no low retics. Usually the reticulocytic count is normal. What are the stages of iron deficiency? I want just to highlight that in the iron depletion, very asymptomatic. The iron deficiency stage, you can have low % saturation of transferrin, you can have hyperactivity and the diminished cognitive function. And this is the stage which we really need to treat. لأن أنت لو ما عالجتهاش ممكن عيال يطلعوا شوية أقل في الذكاء. And this is evidence based. So it can affect their cognitive function, the iron deficiency. So you don't treat those who doesn't need iron, but we need to pick these patients early because it really affects their cognitive function. And بالذات بتأثر على الحساب، ما اعرفش ليه فبيطلعوا No, mass is usually very much affected. Iron deficiency anemia, the stage this very easy, everyone can detect it because the hemoglobin is low and the retics are low, and they can present clinically with pica in the second and third stage. So what is the most common presentation? Usually they are asymptomatic, mild or moderate microcytosis. In severe anemia, which is very unusual, they can present with manifestations of anemia, whatever. We have to look for other causes of the iron deficiency anemia, particularly in severe cases, other than dietary insufficiency by history and examination. Very important to take the dietary history, and can be a confounding finding in children with other causes of anemia, mainly the anemia of chronic disease. So I'm going to take few slides on the neurodevelopmental because it's very important. The iron deficiency anemia decreases the expression of dopamine receptors. And that's why we have impaired the neurocognitive development, including slower visual and auditory processing, and also neurocognitive outcomes, as I told you, are low. And that was the rationale for the routine supplementation and the screening of all infant and young children in the United States. But when they copied this and they did it in Africa, it resulted in a lot of infections. So we shouldn't treat mass, there shouldn't be mass treatment of iron deficiency anemia without making sure that these children are not free from infection. Otherwise, we can have devastating results. The febrile seizures, very interestingly, that though there is no causal relationship between iron deficiency and febrile seizures, however, serum ferritin levels are significantly lower in children with febrile seizures. So there is a recommendation now, those children presenting with febrile convulsions, you should be screened for iron deficiency anemia later on, after we finish the seizures and infection. One of the very rewarding for physicians symptoms of iron deficiency anemia is pica. And when I first joined Oman, the director, the manager of Bank Muscat came to me with two kids, and they were severely iron deficient. And the symptom was they are eating from the wall, they are eating some rice, uncooked rice, and so on. And then I told him, I will give you a magic. Once they receive this, of course, they came classical iron deficiency. Hemoglobin, they depend only on yogurt and milk in their diet, and they are 5 and 7 years old. Very hyperactive, بيتنططوا. قلت له هدي لك دواء يخليهم زي الفل، ما لا يتنططوا ولا يتحركوا يلعبوا ويهيصوا ويروح منهم ومش هياكلوا من الحيط وهياكلوا لحمه. Anyhow, he was very happy. I gave him iron. And those days there was no Nutella ولا فيروبيلا ولا الهبل ده كله، كان الايرن العادي. They didn't, they were not happy about taking the iron, so we give some intravenous iron, and after the second dose immediately stopped the pica. So it's very rewarding. So جاب لي ساعة بتاعت بنك مسقط عندي في البيت. Anyhow, so it is ساعة لا مش فولكس برضه. So they can be also pagophagia, which is craving for ice. And it is particularly common and specific for the iron deficient state. The pica is due to reduction in the neurotransmitter. It can be also, pica is a manifestation in not anemic children, as I will show you on the next slide. So it associates with developmental disabilities. Pica is very common in children with autism, brain injuries, and it is also in the literature. I have seen it in sickle cell disease. But I would like to ask you, Professor Salam, Professor Amal, Professor Mona, whether you have seen pica in sickle cell disease. Personally, I didn't see. I don't know. You didn't. It is. I'm going to ask him. No. You have seen. And he's not iron deficient. Yeah, I didn't see. Yeah, it is reported in the literature. They have pica. They don't have. بس تراو عنده هو الوحيد. سلام. No. Okay.
There are sickle cell patients who are iron.
Yeah, there is. Though it is rare, but it is.
There are quite.
Thank you. In low and middle income countries, randomized trials of iron supplementation have demonstrated benefits of psychomotor development, and even iron therapy has some benefit in breath holding So those breast holding attacks in children can improve with iron. restless leg اللي فينا كلنا يمكن كلنا كنا واحنا صغيرين iron deficient اللي هو يقعد يهز رجله كده لما يطلع روحك واحد قاعد جنبك. And periodic limb movement disorder. So these conditions can be related to iron deficiency. If you pick them early, and personally, I don't have an experience, but this is from the literature. Laboratory assessment, this is from the lab of Professor Firm, that looks like from Ghana. So if the RDW above 14, red blood cell is low, the count should be low, hematocrit is low, MCV is low, MCH is low, and there is some thrombocytosis, and on peripheral smear you find hypochromic, microcytic, and anisochromia. This is usually enough evidence to diagnose the iron deficiency anemia. So red blood cell count is low, and the hemoglobin is low, microcytosis, hypochromia. This is the classical. And if you can see this slide, so the red cell count here is 4 million, hemoglobin is 9.3, there is a match, mild microcytosis and hypochromia and high platelet count. You can see that the RDW is not a very significant marker. However, in most cases of iron deficiency anemia, you have seen it is 20 and 30, but here it is above 14, which is the reported in the literature. The typical that you find in iron of transferrin saturation is very, very low, like in this, it is 2.2. But we don't look usually into the serum iron value because serum iron value is very variable. We look only into transferrin percent of the saturation of transferrin. If you eat one piece of meat, the iron can go up in the lab. لو كلت حتة لحمة هيعلى شوية، لكن الترانسفير هيفضل له percent saturation. The typical classical picture of severe iron deficiency anemia. How to manage? This is from Muscat. 3 steps are essential for successful treatment of iron deficiency anemia in infants and young children. Appropriate dose and the scheduling, dietary modification, very important. Without dietary modification, you cannot succeed, and then you have to follow up the response. The dose is very simple, from 3 to 6. لأنه sometimes إذا كان الولد 20 كيلو تحسب له 6 ياخد 120 ملي جرام iron, sometimes it is very painful for his stomach. So usually you go by the lower dose for the higher weights. Should be given between meals with water or juice, and milk product should be avoided. Now there is this micronized dispersible ferric pyrophosphate, which does not precipitate and is completely dispersible in liquid form. اللي بتحطوا الحاجات اللي هي بتتحط في الحاجات اللي طعمها حلو دلوقتي عن الايرون اللي احنا تعودنا عليه. They have much higher bioavailability, لكن of course they are much expensive. Side effects: abdominal pain, constipation, and diarrhea sometimes. Liquid preparations of iron occasionally cause gray staining of the teeth and gum. Actually, not occasionally, they usually cause, particularly if you give them for a non-iron deficient child. So they have to rinse the teeth, and they really have to avoid rinsing the mouth with water after, and they avoid or minimize by brushing the child teeth. How to follow up? Repeat the CBC after 2 to 4 weeks. An adequate initial response to therapeutic iron is reflected by the following results. أول حاجة تعلى, the reticulocytic response may be seen at 72 hours after treatment initiation, and then the hemoglobin should rise at least 1 gram in 1 month. يعني that means a successful iron. Serum ferritin takes 3 months to normalize. Like if there is no response, this is the most important slide of my presentation, should look into either we have ineffective treatment, like you are not giving enough dose, or the child is not taking, or incorrect diagnosis, like here is a thalassemia trait, or anemia of chronic disease, or mixed nutritional deficiency. We have sometimes a mixed iron deficiency and folate or B12 deficiency. The most important actually cause of the failure is gastrointestinal disease. We had at least in my clinic, I have 7-8 patients of celiac disease diagnosed merely by having iron deficiency anemia that is not responsive to iron therapy, or cow's milk protein intolerance, duodenal ulcer, making diverticulum, يعني continuous gastrointestinal loss of iron, or in cases of inflammatory bowel disease, and nowadays it's taking a lot of importance. Inflammatory bowel disease, usually these patients don't absorb iron properly, and they develop iron deficiency anemia. The other causes of iron deficiency are very, very rare: pulmonary hemosiderosis and of course, the IRIDA, اللي هو genetic causes of iron deficiency. This is a very famous Dr. Salam, I think, jumped by parachute in the Majlis al-Jinn. You have to go into this nice cave in Oman by parachute jumping. I never did it, but I think this is a British guy. So I put this slide because the intravenous iron therapy in the children is really a risk, carries a high risk indication when the patient fails oral iron therapy, iron malabsorption, like in a celiac disease, and also in inflammatory bowel disease. In patients with very severe anemia and the parents are not willing to receive transfusion, or those who are intolerant. في عيال يشوفوا الايرن يرجعوا، مستحيل تديله iron oral, and need for rapid restitution of iron stores like preoperative. So in this particular only indications you need to give intravenous iron. However, in most of patients you don't need. خلاص, and I'm going to finish. What are the iron preparations available? We have the ferrous gluconate, sucrose, iron dextran, and ferric carboxymaltose. Carboxymaltose is mainly used in adult. The one which are most commonly used in our hospital, either ferric gluconate or iron sucrose. And we start with early, with very low dose. The first case of iron deficiency anemia we treated in Oman developed anaphylaxis. After that, we are very, very cautious, and we started, alhamdulillah, he was saved, but it is very dangerous. And after that, we started very low doses as the initial. So please start IV iron therapy in a very low dose. The recombinant erythropoietin or EPO is not indicated in patients with iron deficiency anemia, لكن nowadays used it in inflammatory bowel disease together with the intravenous iron therapy in resistant cases of inflammatory bowel disease, but not in routine iron deficiency anemia. Usually we don't use it. The ferric carboxymaltose, as I told you, it is mainly used in adults, but some reports are in children, and it resulted in a good hematologic response. It is safe, particularly in patients with inflammatory bowel disease. Last, I will talk a few lines about the iron refractory iron deficiency anemia. There is a genetic mutation, it's very, very rare, of the enzyme which encodes the serine protease, which is the matriptase 2. So the matriptase 2 is actually reduced activity will increase the amount of the hepcidin, and that's why the iron intestinal absorption is inhibited. So how you treat IRIDA? Simply by giving intravenous iron, because it affects, however, not all cases respond to that from literature. Personally, I didn't see any case. I don't know anyone in the audience. You have seen one case? That's very interesting. It's a very rare. You have to publish it. I know few only publications about this. I personally didn't see. Anyone? Anyhow. بس نوزن. So this is a congenital lifelong condition present in childhood with severe microcytosis, very, very low mean corpuscular volume, moderate to severe anemia, severe hypophoремia, low transferrin saturation, no response to oral iron supplement, and abnormal iron absorption after an oral challenge. يعني ندي oral iron ونشوف الايرن serum iron هيعلى ولا لا, it will not increase. So that's why it showed that there is no absorption. Incomplete and the transient response to parenteral iron. It is usually transient response, so that is what is in the literature. It has an autosomal recessive transmission, and anemia for some reason often ameliorates into adulthood, like exactly G6PD. معظم العيال عند الادلتhood يبتدوا ياكلوا فول بدون مشاكل, although hypophoремia persists for life. And the take-home messages: iron deficiency is the most common nutritional deficiency in children still. If iron deficiency is unrecognized, it can result in iron deficiency anemia. Children with iron deficiency anemia might have poorer neurocognitive outcome compared with those without iron deficiency anemia. فلازم نحمي العيال ما يطلعوش ضعاف في الحساب. A focused dietary history is the most important screening test for detecting iron deficiency and is more specific than isolated hemoglobin concentration. Like I told you in the story, the first cases اللي ادوني الساعة, only the dietary history بياكلوا بيشربوا لبن وزبادي بس, فدول definitely iron deficient من غير ما تحلل لهم. And then take home also for children with iron deficiency anemia on the basis of history and the initial laboratory testing, dietary management is as important as oral iron therapy. IV iron only if needed in children and should be used with very much caution. Iron refractory is extremely rare. It is actually diagnosis of exclusion. And with these nice photos from Oman, I would like to thank you.
Thank you very much, Dr. Yasser.